Okay, let's dive into this. Welcome to today's Advanced Explainer, where we're going to unpack a truly fascinating postgraduate level topic, pregnancy and leprosy. I mean, for those of us in dermatology and infectious diseases, managing a chronic immunological disease like Mycobacterium leprae is complex enough on its own, right? But when you introduce the profound, systemic immunological shifts of pregnancy into the equation, the entire clinical picture transforms completely. It's wild. Today, we're going to master exactly how that interaction plays out.
So, here's our roadmap for today. We'll move logically through 6 key areas, starting with the immunology of pregnancy, then clinical course and load, Lepra reactions in pregnancy, the fetal and placental impact, childhood and adolescent leprosy, and finally wrapping up with evidence-based practical management. Let's get right to it.
Starting off with Section 1, Immunology of Pregnancy, and specifically the pathophysiological shift.
Okay, so during pregnancy, there is a massive spike in steroid secretion, specifically cortisol and 17-hydroxycorticosteroids, which you can see represented by the molecular structures right here. Now, what does this do? It profoundly depresses cell-mediated immunity, or CMI. And this creates a really fascinating clinical paradox. Think about it. While this depressed CMI actually improves autoimmune conditions like rheumatoid arthritis or ulcerative colitis, it acts like fuel on the fire for diseases that depend on cell-mediated defense. So conditions like tuberculosis and, of course, leprosy see a severe exacerbation.
Now, what's really interesting about the process shown here is the strict dichotomy between humoral and cell-mediated immunity. Driven by elevated estrogen and progesterone, the maternal immune system actively shifts away from a Th1 response over to a Th2 response. On top of that, plasma proteins like pregnancy zone protein, or PSP, and placental protein 14 directly modulate T cells to push that CMI even lower. And this suppression, it stays locked in throughout the entire pregnancy. But the moment the patient enters the puerperium or postpartum period, that CMI aggressively regains its strength.
Guys, this right here is a classic high-yield examination point for MD Derm residents. You absolutely must know the exact cytokine profile shift. We see a distinct downregulation of Th1 cytokines, literally a failure of interleukin-1, interleukin-2, and interferon gamma. But at the exact same time, there's a marked upregulation of Th2 cytokines, like IL-4 and IL-10. Now sure, this Th2 upregulation is immunologically protective for the fetus. It prevents rejection, which is great. But it completely strips away the host's ability to contain Mycobacterium lepra. It leaves the door wide open.
Let's move to Section 2 and see how this builds. Clinical course and load, focusing on the timeline of exacerbation.
Believe it or not, 20 to 30% of female patients present for the very first time during their pregnancy. Notice the clinical photographs here. What starts out as a super mild subclinical presentation, maybe just a solitary, well-defined papule or plaque, can suddenly erupt into severe reversal reactions characterized by acute erythema and multiple edematous nodules. Why? Because the CMI is so depressed initially, M. leprae basically multiplies unchecked. Then, as the patient hits the puerperium and CMI finally recovers, the immune system suddenly wakes up, recognizes this massive bacillary load, and bam, triggers these explosive inflammatory cutaneous changes.
So the bacillary journey progresses directly from pregnancy into lactation. During pregnancy, that suppressed CMI essentially pushes the patient's disease classification right toward the lepromatous pole, maximizing the bacillary index. But then lactation hits, the mother regains her CMI, and the disease experiences a sudden immunological upgradation. It's exactly this sudden, aggressive cellular attack on the newly expanded bacillary population that precipitates those severe reversal reactions.
Let's walk through this chronological timeline step by step. In the first and second trimesters, the disease slides toward the lepromatous pole. By the third trimester, the patient hits her maximum bacillary load. Finally, in the puerperium and lactation phases, CMI rebounds. It is absolutely vital to note that because of the prolonged immunosuppression, combined with the fact that mothers are often really reluctant to take systemic meds while pregnant, these persister bacilli multiply rapidly. If we leave this untreated, relapse isn't just a possibility, it's virtually inevitable.
All right, Section 3, Lepra reactions in pregnancy, specifically comparing type 1 versus type 2.
So the crucial point here is understanding exactly when and why type I reversal reactions occur. They predominantly peak 3 to 16 weeks after delivery. Look, during pregnancy and early postpartum, CMI is still relatively low, so the immune system only really reacts to the surface antigens of the multiplying bacteria. That just leads to cutaneous lesions. However, during lactation, CMI spikes aggressively. It literally destroys the bacteria, uncovering deep cytoplasmic antigens hidden within the nerves. And that is why lactation triggers such severe, limb-threatening neuritis and nerve function impairment.
Now contrast this with type 2 reactions, or erythema nodosum leprosum. Unlike the cell-mediated type 1, type 2 is an immune complex-mediated reaction. It typically peaks earlier, right in the third trimester. This is driven by an incredibly high antigenic load, which we often see in untreated patients or borderline lepromatous cases. Clinically, you're going to see severe recurrent cutaneous ENL nodules, accompanied by some pretty significant constitutional and systemic symptoms.
Moving on to Section 4, Fetal and Placental Impact, looking at the collateral damage.
When we shift our focus to the fetal impact, there is robust experimental evidence of transplacental infection. This leads to lepromatous placentitis, where acid-fast bacilli can literally be found in fetal spleens. Because of fetal placental inadequacy and a lower mean estrogen excretion, which is especially prominent in mothers with lepromatous leprosy, these fetuses suffer from pronounced intrauterine growth restriction, or IUGR. You'll also find specific IgA and IgM anti-M. lepri antibodies right in their cord blood. And when examining the placenta itself, the histopathology is honestly quite fascinating. The overall morphology and cell number remain totally normal. However, the actual physical size of the placental cells decreases, which leads to a significantly decreased total placental weight, even though the tissue itself frequently tests positive for acid-fast bacilli.
This brings us to a specific, high-level postgraduate metric you simply must be familiar with, the placental coefficient. This is essentially the ratio of the baby's weight to the placenta's weight. As highlighted by the bar charts and the associated microscope graphic we're looking at, in pregnant women with leprosy, this coefficient is significantly decreased compared to healthy pregnancies. It serves as a vital clinical marker of compromised fetal placental health and intrauterine developmental restriction.
All right, Section 5, Childhood and Adolescent Leprosy, focusing on those long-term impacts.
We have to realize the systemic impacts on the child are severe. Up to 20% of children born to mothers with leprosy will actually develop the disease themselves by puberty. Alarmingly, 80% are severely underweight and face a much higher incidence of serious respiratory problems and infant mortality. For the kids who survive into adolescence, we see delayed pubertal skeletal growth spurts, and in girls, delayed menarche. All of this stems directly from that severely impaired in utero environment.
Okay, let's dive into how we actually manage this clinically, based on WHO standard MDT guidelines. Section 6, Evidence-Based Practical Management.
Let's unpack this dense pharmacology table. For standard multidrug therapy, dapsone and clofazimine are continued, but you have to be aware of neonatal hemolysis and skin discoloration. Rifampicin requires prophylactic vitamin K for infants. But crucially, look at the contraindicated medications here. Quinolones are avoided due to arthropathies, minocycline causes infant teeth discoloration, and thalidomide is absolutely 100% contraindicated, no exceptions. If you need to manage reactions, be super wary of NSAIDs in the third trimester. They cause oligohydramnios and premature closure of the ductus arteriosus. And if you're using corticosteroids, you've got to monitor vigilantly for maternal hypertension and hyperglycemia.
Clinically, the algorithm is straightforward but strict. If a woman with leprosy becomes pregnant, or a pregnant woman is newly diagnosed, she must complete the course of anti-leprosy treatment. Do not stop MDT. Her care should be managed at a specialized perinatal center. You need to meticulously look out for new sensory motor deficits, signaling nerve damage. And remember, never under any circumstances prescribe thalidomide for ENL in a pregnant patient. As a clinician, you also really must anticipate neonatal side effects from maternal MDT so you can counsel parents effectively. For instance, dapsone can cause exfoliative dermatitis in the newborn's first hours of life, and clofazimine will cross the placenta and breast milk, causing a reversible brownish skin discoloration in the infant. Now, it's worth noting that despite the presence of M. leprae in breast milk, breastfeeding remains completely safe and retains its vital protective immunological benefits.
Let's use this brilliantly illustrated cycle by Duncan M.E. as our ultimate lecture summary. Follow the arrows with me. Maternal CMI drops during pregnancy, leading to overt leprosy and a high bacillary load. This branches into two paths. First, fetal infection resulting in low birth weight. Second, postpartum CMI spikes. That spike triggers those devastating type 1 reversal reactions, leading to catastrophic nerve damage and long-term disability for the mother, while the child unfortunately carries the subclinical infection right into the very next generation. It's a brutal loop.
So just to summarize our high-yield takeaways. Pregnancy forces a Th2 immunological shift, depressing CMI and skyrocketing the M. lepra bacillary load. Postpartum CMI aggressively rebounds, triggering severe type 1 reversal reactions and dangerous neuritis. The fetus is at high risk for IUGR and transplacental infection, which we can track by a lowered placental coefficient. Clinically, MDT must be maintained, but teratogens like thalidomide, quinolones, and minocycline are strictly out of the question. We literally have to break this cycle. So, as future leaders in dermatology, I leave you with this. How can we better integrate advanced, high-risk perinatal care with hypervigilant dermatological monitoring to truly protect both maternal nerve function and fetal development? Thank you so much for joining me on this deep dive. Keep learning, and I'll see you next time.